Let us look at the algorithmic approach to a patient of hypoglycemia. So we start with a patient of suspected or documented hypoglycemia. The first question is he a diabetic or a non-diabetic? Because diabetic hypoglycemia is different. Non-diabetics having hypoglycemia, the causes are different and management will be different. Diabetic hypoglycemia, if we know that the patient is a diabetic, is he on insulin? Is he or she on sulfonylurea or other secretagogues like ripaglinide or metiglinide? This is important because these are the drugs we know which have the potential to cause hypoglycemia. Then adjust the regimen, adjust the insulin dose, reduce the sulfonylurea or withdraw the secretagogue and add on a sensitizer like metformin or thiazolidine or use a DPP-4 inhibitors. Document improvement and monitor the patient. This is what we need to do, and hypoglycemic episode, if we recognize them in hypoglycemic episode, immediately treat with oral glucose or intravenous glucose. Okay, if the patient is not a diabetic, then there are two courses. Are there any clinical clues or is the patient apparently healthy? If the patient does have some clinical clues like use of drugs which can cause hypoglycemia, sulfonamides, pentamidine and many other drugs which we have listed, or he has got organ failure like hepatic failure, renal failure, cardiac failure, or he has got very severe sepsis which could be the cause of hypoglycemia, or hormone deficiencies like Addison's disease, or non-beta cell tumors which produce excess of insulin, or previous gastric surgery, dumping syndrome, and these things should be considered. Provide adequate glucose, treat underlying cause, immediate treatment with glucose and treat the underlying cause. That is for people who have got recognizable other causes of hypoglycemia. Supposing the patient is healthy and doesn't have any other clues and is not a diabetic, not on oral drugs, then fasting glucose should be measured. If the fasting glucose is less than 55 milligrams or more than 55 milligrams, if the fasting glucose is less than 55 milligrams, then probably excess insulin and look for Whipple's triad. Whipple's triad is hypoglycemia symptoms, then there is blood sugar is low and the treatment improves the symptoms. Then measure the insulin is more and the Whipple's triad is positive, then measure the C-peptide. If the C-peptide is low, then it is probably due to endogenous insulin, which is called, if the C-peptide is increased and insulin also increased, endogenous insulin production is more due to insulinoma or autoimmune diseases wherein there is an antibody to insulins which potentiate the insulin action, or there is a sulfonylurea administration, probably fictitious. A non-diabetic patient taking sulfonylurea, with the result there is endogenous insulin is more, C-peptide is also more, because of sulfonylurea most likely causes fictitious hypoglycemia due to sulfonylurea. Supposing if the C-peptide is low and the insulin is high, then he is not taking sulfonylurea but is taking exogenous insulin. Again, fictitious use of insulin should be suspected. So, if the hypoglycemia is not that severe, it is in the milder range of more than 55 milligrams, then history is important. If the history is strong, then extend the fast, check the blood glucose again. If the glucose comes down to 55, look for Whipple's triad, look for C-peptide, look for insulin and go this pathway. If the blood glucose still remains even after fast more than 55, then give him a mixed meal containing fats, carbohydrates as well as these things, and mixed meal contains all types of foods. Whipple's triad, if it appears again, and then it is a case of reactive hypoglycemia or postprandial hypoglycemia. There is no Whipple's triad and then the blood glucose continues to be more than 55 in spite of extended fast and then giving glucose, then hypoglycemia is excluded, and some people with normally also that they will be able to manage with that blood sugar of around 55 without having hypoglycemia. So this is in nutshell the algorithmic approach for a patient with hypoglycemia. So dear friends, we have extensively considered the pathogenesis, the counter-regulatory mechanisms, the types of hypoglycemia, the presentation, the autonomic symptoms, the neuroglycopenic symptoms, then the different special scenarios, situations, reactive hypoglycemia, hypoglycemia unawareness, hypoglycemia associated autonomic failure, and special precautions to be taken in diabetics. What are the risk factors for hypoglycemia? What are the preventive strategies of preventing hypoglycemia? More importantly, the monitoring of the blood sugar, the Whipple's triad, the treatment of hypoglycemia with oral glucose and mild to moderate, in severe cases with intravenous glucose, 25 grams of intravenous glucose available as 25% solution, or glucagon in selected individuals. And of course, finally, we have seen the algorithmic approach, how to work up a patient of suspected hypoglycemia. All these things have been covered. I thank you very much for your patient listening, and I hope that you have enjoyed this talk and made things clarified as far as hypoglycemia is concerned. And I again look forward for another occasion to be with you in a future CME. So once again, thank you all.